coming. The event is something that myself and Emily have both been quite excited to host and get involved in. We're both keen athletes, myself in running and rowing, and Emily in running and competitive gymnastics. So keen sportswomen, and both had a long interest in the interplay and the interdisciplinary connections that are involved in injury and sports performance. So we've got some amazing health professionals coming in today to speak to us that Emily's going to introduce in a second, and we hope you enjoy.
So joining us today, I'm very excited to introduce Dr. Jooste, who is busy completing his PhD in sports medicine, Dr. Barrow, who is a specialist gastroenterologist. We also have Claire Ann Kilroy, who is a physio, and then lastly we have Prof. John Patricius, who is also a sports physician. Thank you so much for coming, and we are really keen to hear inputs. And then also joining us, we have Jack Sneeman from the Sweatshop, who will be sponsoring our raffles. And then just in terms of the agenda and how the event will be running, so each presenter and each speaker will have a quick, brief 15 minutes presentation on their speciality, followed by a Q&A. If you could preferably keep this more discipline specific, and then once all the speakers have presented, we will open to a Q&A for a more broad, multidisciplinary panel discussion. Thank you so much for coming, and I hope you enjoy. And then we're going to introduce our first speaker.
So first up, we'd like to welcome Dr. Marcel Jooste. I'm going to read his biography for those who haven't seen the Instagram already. So Dr. Jooste is the head of the Sport and Exercise Medicine practice at the Sport, Exercise, Medicine and Lifestyle Institute in Pretoria. Dr. Jooste provides medical care to numerous national and international athletes and teams. He is also the past chief medical officer of Rowing South Africa and traveled with the team to major international events. Dr. Jooste is currently completing his PhD in sports medicine at the University of Pretoria, and he has been recognized as a fellow of the South African Sports Medicine Association. He also lectures voluntarily for the sports medicine program at the University of Pretoria. So without further ado, Dr. Jooste. Yes.
Keep my slides to the next one. Can I just press? Yeah. Cool. All right. Good evening, everybody. And first of all, thank you very much for the kind introduction and just the invitation to be here. It takes me back many years to when I was in a similar position to what you are, and I think it's such a privilege to be able to be exposed to different specialities while you're still in your medical careers or studying to become medical professionals. And I think the more we can broaden our minds of what we can do with our professions, the more fulfilling they become. And so my hope for you this evening is not to convince you to become a sport and exercise medicine physician, but just to enlighten you of the different fields that do exist in this beautiful career path which you have chosen. Okay. All right. So, did you know that sport and exercise medicine is the fastest growing medical specialty in the world? According to the Association of American Colleges of Medicine, the number of sports physicians increased by 43% from the year 2016 to 2021. Now, sports medicine was once primarily tailored towards management of elite athletes to enhance performance. But increasing evidence of the benefits of exercise in the management of multiple medical conditions has helped put the specialty at the top of this list of growing medical specialities. So, for those of you who don't know, what is sport and exercise medicine? It's a branch of medicine that deals with the prevention, treatment, and management of injuries and illnesses related to participation in sport and exercise. It serves all people, from your elite athletes to those living with chronic diseases. sport and exercise medicine has four main focus areas. Number one, the prevention, diagnosis, and management of injuries and exercise-related medical conditions, such as breathing-related issues or gastrointestinal issues, certain cardiovascular issues. The third pillar is facilitating a healthy lifestyle and managing non-communicable diseases such as diabetes and cardiovascular diseases, through exercise prescription and lifestyle interventions. And lastly, optimizing human performance in athletes of all levels of participation and facilitating team care through evidence-based training principles based on physiological testing, biomechanical analysis, and optimizing recovery strategies, load management, and collaboration with various colleagues, including sports scientists and even coaches. So, sports medicine can trace its history back 5,000 years ago to East Asia, where the Taoist monks in China advised healing exercise to cure certain illnesses. Fast forward to 400 BC, when Hippocrates, who was initially skeptical of the benefits or the healing powers of exercise, was eventually won over. And he wrote in one of his papers titled On Diet that eating alone will not keep man well. He must also take exercise. And further elaborated by stating that in order to remain healthy, the entire day should be devoted exclusively to ways and means of increasing one's strength and staying healthy. And the best way to do so is through physical exercise. Perhaps slightly over the top, but he got the message. All right. Now, what about sport and exercise medicine in South Africa? Many of you may be aware. For those of you who aren't, I'm going to give you a brief rundown. The journey to establish sport and exercise medicine as a clinical speciality in South Africa began in 1990, when the first sport medicine postgraduate program, the training program, was initiated. After 2 decades of engaging with regulatory bodies such as HPCSA, the Colleges of Medicine of South Africa, finally in March 2020, sport and exercise medicine gained formal approval as a registered medical speciality in South Africa. Today, sport and exercise medicine stands as the newest medical speciality in South Africa. Currently, the registrar's training program is still being developed, and I'm sure Prof. Patricius will share more about that. But there are postgraduate master's programs still being offered at a few universities. So, a key principle of sport and exercise medicine is the emphasis on the multidisciplinary collaboration, facilitating and holistic care of all patients. Now, why is the multidisciplinary approach so important? Because of the complex nature of injuries, health, and performance optimization. It's never just about one thing. There's often a psychological aspect to it, or a mental aspect to it, or a nutritional aspect to it, or a load management aspect to it. Therefore, there's a need for diverse expertise to address various aspects of an athlete's health. And we achieve improved outcomes through integrated care. Now, in order to explain this a bit more in a clinical way for you, I'm going to share a real-life example of a clinical case that required a multidisciplinary approach. Okay, so the case involves a 21-year-old university student athlete. She presented with a 2-year history of excessive fatigue, muscle soreness, especially after hard training sessions, recurrent upper respiratory tract infections, especially after periods of intensified training. She had spent the previous 2 years in the USA on a sports scholarship, which entailed a very high training load over these 2 years. And she was now underperforming in all aspects of her life, on the athletics field, to academics, and even struggling mentally. Now, I'm not going to go through the entire case, but essentially this was a complex case of what we call overtraining syndrome or unexplained underperformance syndrome. The message of this case is that we were able to identify multiple factors that were potentially contributing to her overall condition. Okay? Now, to illustrate this multidisciplinary collaboration that is required to manage the case, I will briefly describe the role that I played and how I facilitated and managed this case. So my role as a sport and exercise medicine physician was, first of all, to perform a thorough clinical assessment, to establish an accurate diagnosis, and then to facilitate or implement a treatment plan. This entailed facilitating return to play decisions, when could the athlete return to sport, as well as overseeing the medical oversight of the case by coordinating care through facilitating communication and integrating the expertise of different disciplines. So, firstly, I had to optimize her current medical conditions. She had asthma and allergic rhinitis, which were suboptimally treated, so I addressed those. Secondly, I identified and treated other underlying general medical conditions contributing to her symptoms. She had a tinea capitis fungal infection, which we treated. Amongst other blood tests, I identified that she had iron deficiency, which we managed. She had a vitamin D deficiency, which we also had to address. And then I even entered into discussion with a pathologist because blood tests for bilharzia were equivocal. And the outcome of our discussion with the pathologist was that she actually had a chronic active bilharzia infection, which we then also had to treat. So next, I referred her to a dietitian because she had inadequate caloric intake to support the demands of not just her training, but her lifestyle. And we focused specifically on increasing the amount of protein that she takes in, because she had a severe muscle loss over the last 2 years. Thirdly, I referred her to a psychologist. She had developed severe anxiety from underperforming, struggling with her studies, and even relationship problems. And she even had symptoms of depression. Fourth step was a discussion with her coach about the temporary cessation of a structured training program. And then we gradually increased the amount of training over a period of a few months. And lastly, I referred her to a biokineticist for functional rehabilitation of a niggling Achilles tendinopathy, which she had not addressed properly. So the takeaway from this case presentation is that we should remember to treat the athlete with the problem, not the problem of the athlete. And this entails a team approach. Treat the whole patient. Like I said, this often entails a multidisciplinary collaboration to achieve optimal outcomes. Now, I encourage those of you who are remotely interested in sport and exercise medicine to consider this newest medical speciality in South Africa. Exciting times are ahead, with lots of research opportunities and novel ways of integrating this speciality into both the private and the public healthcare sector. Thank you very much for your time. I'll like to take some questions now or afterwards. Cool.
If there's any questions for Dr. Jooste, if you could please just raise your hands and or ask, to be honest.
What inspired you to get into sport and exercise medicine?
That's a great question. And before I answer that, I think that's a question that every one of you should ask yourself somewhere along your medical journeys. What are your passions? And follow those passions. And from a young age, sport and exercise has always been a very big passion of mine. And I was fortunate enough to, unconventionally at the time, get exposure to sport and exercise medicine because it wasn't as well recognized and readily available as what it is for you today. But I was fortunate in my fourth year of medical school, in my fifth year, I did an elective in sport and exercise medicine. And from there, I built a relationship with those people that I met, and my passion grew for the field, and I knew that's how I could best serve people, is through using my passion and using my career as medicine and combining those two. Yeah.
Doctor, regarding the patient, the bilharzia assumption and your consult with pathology, was your patient a rower? Firstly, or your athlete, were they a rower? And secondly, with a female athlete, did you, when you referred to the dietitian, was it the relative energy deficiency, was that your diagnosis and that's why you referred to the dietitian?
Great questions. Yeah, I like the way you think clinically. And I don't want to deviate from the idea behind this talk, so I'm just going to very briefly answer those two clinical related questions. I'm happy to have chats with you afterwards if you want to go more in depth. Firstly, no, the patient was not a rower, but bilharzia is something that we do keep in mind with athletes that are exposed to open water, that's just open water swimmers, rowers, triathletes. She may have been exposed in her high school years rather than later on. Secondly, relative energy deficiency in sport is a very complex, yet I think underappreciated condition, which some of you may be aware of and some may not be. But she definitely had certain aspects of that, but not enough to have the official diagnosis of that. But many of the managing principles, the principles behind the management, how we treat this athlete remain the same. Yeah.
So we have an online question.
Cool.
One of our listeners asks if chronic bilharzia is usually asymptomatic.
I mean, I'm no expert in this, just first off, but as I understand, there are subtle symptoms of which underlying chronic fatigue is one of the most common symptoms which these patients do display.
And then I've also got a quick question. So I know you work with some sports teams, like the rowing team. Could you give us a brief overview of the kind of multidisciplinary approach that you take with a team as opposed to an individual, with a more like constant sort of management style?
Yeah, so a lot of that is determined by the resources available to a team. For example, if we are working with let's take for example a rugby team of South Africa, the Springbok rugby team have almost endless financial resources. So they are fortunate enough to have access to multiple different specialists and almost different team members, if we can call it that. For example, when I worked with rowing South Africa, we have a very limited budget. So what we had a sport and exercise medicine physician, myself, I almost, with myself, a biokineticist and a physio. So I almost had to play multiple roles of almost as a dietitian or something, almost as a psychologist. Never playing that entire role, but helping where I could, and knowing when I've reached my limit of what I am capable of doing, then referring to someone outside of the team, with the knowledge that this does have financial implications for us as a team. So it really depends on the resources available to you. Yeah, I hope that answers your question.
Yes, it does. Thank you.
Do you have any more questions? Okay, cool.
Cool, thank
Thank
you.
you.
All right.
Okay, next up we have Dr. Peter Barrow. Dr. Peter Barrow is a consulting gastroenterologist at Wits at Donald Gordon Medical Center. After specializing as a physician at Wits, he completed his subspecialist gastroenterology training in 2005, including a 3-month fellowship at the Free University Hospital in Amsterdam, where he was introduced to an advanced interventional endoscopy. From 2005 to 2008, Dr. Barrow established the first endoscopic ultrasound unit in South Africa with a private-public partnership allowing state patients to undergo advanced procedures in private. In 2008, Dr. Barrow was invited by Mediclinic to help establish the first private gastroenterology unit in Dubai Healthcare City, United Arab Emirates. As far back as 2012, he was involved in his first fecal transplant in South Africa for treatment of recurrent or resistant C. difficile. He has specialist interests in celiac disease, inflammatory bowel syndrome, endoscopic ultrasound, has numerous diverse publications, and has been involved in clinical research in various fields of gastroenterology, and is currently national PI of 2 inflammatory bowel disease trials in South Africa. And it also was not mentioned, but he is a fun runner and has done a few comrades, if I'm not mistaken. Please come and join us.
Sure, guys. Thanks to the organizers for inviting us. This is a privilege to join you guys and come back to med school. It's always quite emotional to come in and see stuff. But anyway, so let me I was asked to talk about gastroenterology, its role in sports and exercise medicine, and I was asked today about, am I a surgical gastroenterologist or a medical gastroenterologist? And my answer is, I'm a gastroenterologist. You don't have surgical gastroenterologists. You have surgical gastrointestinal surgeons, although they like to call themselves gastroenterologists. So just like you don't have surgical cardiologists, and you have cardiothoracic surgeons. But anyway, it's semantics. Gastroenterology, unfortunately, a lot of you guys aren't exposed to a lot of the outpatient gastroenterology, and I'd say about 80 or 90% of my work is actually outpatient work. So you guys are exposed to the surgical side of gastroenterology, and a lot of your training is very much hospital-based. But in fact, the second most common reason why patients go to a doctor is for GIT problems after the common cold. So it is really a very important part of your medical understanding to try and help these patients. And what I'm going to briefly talk about is its role in sport. And I can't do justice to that, but I'm going to try. Now, I've asked to block this because I had her permission to talk to you about her, but not to the whole world. I don't know if you know who this person is. She's the third most successful South African golfer after Gary Player and Ernie Els. This is Ashley Simons, now Ashley Buhai, who I was hoping would win the LGPGA this weekend, just in time for the talk. She was winning for the first 2 rounds, and then unfortunately bombed out in the 3rd round. But that's the picture of her winning the British Open. So a lot of you probably don't know this. These are pictures of her winning the Australian Open, South African Open, and various other international courses. So she's got the 3rd most number of professional wins out of all South African golfers. The story about her is that at the age of 14, she was the first winner of the South African Open at the age of 14. She was this childhood prodigy, and she was destined to go on to great things. The day she turned 18, she turned professional and won her first ladies PGA tournament in a European tournament at the age of 18. But then suddenly her life crashed, and like what we've talked about, she was then started to underperform. And she was traveling the world trying to compete in golf tournaments, and she was going from doctor to doctor to doctor, sports physician to psychiatrist, psychologist. She was diagnosed with bilharzia. She was diagnosed with iron deficiency anemia. She was diagnosed with anxiety. She was diagnosed with a whole bunch of issues. But she also had a very upset stomach. Unfortunately, she went to a surgeon and had scopes done, and nobody found any cause of her problems. And eventually, she was referred to me actually because of her iron deficiency anemia. And that was in 2016. And at that stage, all we did was a simple blood test looking for celiac disease. So that's another cause of iron deficiency. And it turned out that she actually had celiac disease. Now, I don't know if you guys know about celiac disease. You're probably never going to see a patient in the hospital. But celiac disease is gluten sensitivity. And getting a dietitian involved and working with her coach and sports physician, we got her onto a gluten-free diet. And if you look at her, this is her earnings from 2016 going up to now. And unfortunately, 2025, we can't really go on there. But this is in US dollars. So it's gone from basically 0, and suddenly suddenly you can see there's a big shift. And this is the role that her dad plays. This is when she won the British Open. Now you can say, okay, well maybe this is what happens as you get older in golf. But in fact, if you look at what happens in most females, this is the LGPGA wins average. Normally, by the time your peak is when you're about 27, 28, and then you go down. So Ashley Simon or Ashley Buhai has had that peak going up after the age of 28 to 30. So unfortunately, there was about 10 years of misdiagnosis where she was really struggling, and it was actually we were lucky to get involved and change her entire span of her career as a gastroenterologist. So that's just an example of where gastro can come in, but it actually doesn't mean gastro. It's any medical doctor looking at holistically needs to can help these patients. Now, when you look at the gastrointestinal system as a student, I always thought of it as this an anatomical structure that starts from the mouth and goes all the way down. And if you're lucky, you remember the pancreas and you remember the liver. But in fact, it's a neural organ. 95% of your serotonin, which is what you get from chocolates and your antidepressants, is actually found in your gut. It's an endocrine organ. The first hormone that was ever discovered was actually secretin, way before insulin. And we've got new sort of peptides and substances that we're learning about. It's also probably the most important immunological organ in that it's involved in your innate and your acquired defenses. 80% of your blood's immune system is actually focusing on your gut. Some of it's in your lungs, some of it in your skin, some in your brain, but most of it is focused on your gut. And then obviously now you guys are all aware of the microbiome, and that's a whole new topic that we need to talk about. But that's now going into the realms of gastroenterology, and this microbiome story is probably going to become the new speciality after sports medicine. But why is the GIT involved, and why are we talking about sports medicine? Basically, 80%, more than 80%, especially of runners and especially of extreme runners, will end up having GIT symptoms. What are the symptoms? Cramps, urgency, so having to run to the toilet, nausea, vomiting, diarrhea, reflux, chest pain. These are all common symptoms in any person doing any exercise, but in fact they're common in everybody. But why? And the issue is when you're exercising, there's change in blood flow, there's the distance of your blood to get to the muscles it needs, you've got neurological control, I've talked about a little bit about hormonal control, you've got the motility of its own gut, you've got the absorption capacity, and then what's new on the block is this disruption of the microbiome and what exercise does to the microbiome, both benefits and problems. So what happens when you're exercising? You're getting this relative splanchnic ischemia, so you're shunting blood away from your gut. That alters the motility, you get altered absorption capacity, you get the altered microbiome, you talk about this leaky gut, and in fact you may even end up with this mild endotoxinemia, which leads and may be part of this extreme, your ultra athletes, when you're watching comrades at the end, everybody's collapsing and head off to the medical tent. It actually all might be related to your gut, leaky gut. Anatomical changes, I mean, I was trying to debate on who we should present. I've got another interesting patient who's had a stoma, who runs without a colon. There's a good YouTube video on this guy. He had ulcerative colitis and was nearly dead and had his colon removed. Obviously that's going to impact in how he has to keep rehydrated. Dietary, we've briefly just touched on one of the athletes. Physiological, exercise-related, age-related, microbiome. We can go through all of these specialities. They all play a role in modifying how you respond to exercise. This is quite a complicated drawing, but basically we know that exercise decreases your risk of colon cancer, improves patients with IBS, may improve symptoms of diverticulosis. Those are medical. There's some new kids on the block here. So there's brain-derived neuropathic factor, which I don't know if you guys have been learning about. It's a type of a signaling peptide that helps control of your nerves. Like serotonin, it's highly expressed in the gut and probably has a very important role in exercise. We've got depression, anxiety, how that affects the gut. What exercise actually does, increasing butyrate function, which is basically feeding your gut, and what effect this has on the gut. I'm going to show you a reference at the end of this to this article, but basically what excessive exercise does to your gut. And I've mentioned a very controversial term just now about leaky gut, and we've briefly touched on the microbiome. But what exercise actually does and how it acts as an anti-inflammatory, but excessive exercise can act as a pro-inflammatory problem. And excessive exercise may be ultimately causing a little bit of endotoxinemia to your body related to the translocation of gut bacteria and gut bacterial proteins. So with that as a background, what is the role of the gastroenterologist? In 2025, the main role for us is to try to identify something that's not going to kill you. If you think about it, when are you going to die? You're going to have a heart attack, stroke, or you're going to get cancer. That kills 80% of people. So look after your blood pressure, look after your cholesterol, and then check for cancer. And 50% of cancers that kill people come from the gut, which is esophageal, stomach, colon, and pancreatic. So my main job as a gastroenterologist is to stop or try to identify something that's going to kill you early. And your red flags you need to know about are melena, unexplained weight loss, family history of cancer or inflammatory bowel disease, and what I put at the bottom there is anemia. That should never be ignored, because that's often a sign that something's going wrong. Whether it's bilharzia, whether it's celiac, you must identify that cause of anemia. The patient we presented earlier and the other one basically was often, she's a young female, she's menstruating, put on iron tablets, and that's the cause of her iron deficiency. But there often is something more to it. In terms of investigations that we look at as a gastroenterologist, the full blood count, iron studies, and B12 are very important. And if you're looking to screen your gut, you don't have to go for scopes. The reason for a scope is to look for cancer. But to look for problems, you can get away with looking at stool tests. So a stool test for a gastro is a bit like a blood test for a normal doctor. You can check Calpro, you can check for evidence of bleeding, and we talk about this H. pylori, it's a whole part of the thing, but that's actually part of your microbiome. It comes on to dietary recommendations. Now, I don't know how long I've been going, but I could spend, each slide here we could spend a day talking, but the Mediterranean diet is where we're at in 2025. No matter what some of the sports physicians say, this is the way to go. If you're struggling with your gut, we start off limiting dairy. Dairy, I tell patients, is for baby cows. You don't see a lot of adult cows running around drinking milk. It's a good sort of protein, so you may be using your whey protein. Low fat, if you're struggling. We talk about this low FODMAP diet. I don't know if you know the FODMAP diet. It's all the fermentable carbs. And then another big problem that we see with people with gut issues is all the energy sachets all loaded with caffeine. And you've got to be a bit cautious with caffeine, especially if you've got a bit of a sensitive tummy. Everybody wants to know about probiotics and supplements. basically most probiotics are just a combination of lactobacillus, which is yogurt, and bifidobacterium, which is actually often a bacteria derived from your skin, which you get from breastfeeding. But probably what's more important is your prebiotics, and I'd be interested in what the sports guys are talking about, because I've just listed some. There's curcumin, which is an antioxidant, which is in turmeric. There's green tea as an antioxidant to try and protect the gut. You've got boswellia, which is actually old frankincense going back to the Bible and even before Hippocrates. Cranberry juice, which is increasing nitric oxide, which is increasing blood flow to your gut. I know the British Olympic team swears by beetroot juice as an anti-inflammatory, antibacterial. Berberine as an anti-inflammatory, comes from the bark of a specific tree, are all things that people are using which can modify your gut. As a gastro though, we can try, and you have to know about this, but we go on, the first thing that we use is obviously antacids, and I'm sure you guys have all learned about PPIs, proton pump inhibitors, but H2 antagonists are actually also very useful as on-demand therapy, probably more useful than a PPI, which often takes a bit more time to work. So if you need something on demand, your H2 antagonists, cimetidine work well. Then we talk about muscle relaxants, your anticholinergics, antimuscarinics. I don't know if you can remember all this stuff. Anti-nausea medication. We tend to use a lot of these 5-hydroxytryptase, which is like serotonin but different antagonists. And then we do use quite a lot of constipating agents sorry, I suppose spelling mistake in constipating, but in terms of symptomatic treatment, once you've excluded organic problems, and I've just mentioned, if you're interested in some of the nutritional supplements, because every single patient that's ever come to me wants to know how to treat their guts with diet. This is an interesting article recently published on sports-related GI problems, which it's open access. So with that as a brief introduction, it's nice to be here with all you guys, and it brings back memories. So as you were saying, it's quite fun to come back to medical school. And sorry, I got a bit emotional in the beginning. Any?
Yeah, we're going to open the floor to questions if anybody has any questions. No questions. I have a question from, okay, you guys go, sorry.
I noticed with the dietary recommendations, we were talking about like you limiting caffeine, limiting fiber. Are all those limiting just in the beginning until you can get the gut working properly again? Because I know it's like fiber is obviously quite important in terms of colon cancer and preventing it.
Yes, so a lot of these things, so again, talking at a multidisciplinary, I think specifically with dietitians play a massive role. I think every single sports team will have and every single high sort of performing athlete has a dietitian on tap. So I'm not a dietitian, but generally, if you've got a gut issue, most of the problems that we see are nausea, vomiting, and diarrhea in high-end athletes or people trying to start exercising, and especially the runny tummy, loose stools. We talk about going on a low residue diet, often just before any major event. So if you're trying to run a marathon, you're going to struggle if you've gone and had a big creamy pasta with lamb pasta with high fat, a lot of dairy products the night before. So going on a low residue, sort of a simple based carb diet will definitely reduce your risks of having to run off to the toilet after a couple of Ks into the race. A lot of this stuff, so as a baseline, we don't like limiting anything as gastro. So we've talked briefly about the microbiome. There's the American microbiome study which showed that the more diverse your diet, so they actually came up with the 30 plant a week diet. I don't know if you guys have read about this. You might have been on TikTok. It was in that you have to go and count your variety of plants, and that what they've showed is the more variety you have, the more diverse your gut microbiome. It's actually more important, the diversity of your diet, than actually whether you're vegan or vegetarian or meat eater. So you can you actually, the more diverse your diet, the better. But when we talk about issues like pre-race or exercise-induced diarrhea, these are the things that we would start limiting. Would be try cut out your dairy as the first line. Limit, go on to low residue, limiting your fiber, limiting fats. That's in somebody who's got an issue with sports and exercise. I don't know if that makes it clear, but the recommendation is still have a very good, healthy, diverse diet.
I just have a question. So there's a huge prevalence of everyone diagnosing themselves with lactose intolerance after, two encounters with milk, like 10 years in the future. And everyone just thinks that they diagnose themselves, right? So my question to you today is, what is a red flag? Like, for someone who has something like, maybe I just thought it was this, changed to almond milk, but what are the dangers of having a constant diarrhea, the upset tummy? Could it be, yeah.
So lactose intolerance, I think, so there are specific tests we can do. There's something called a breath test. But to tell you the truth, there's no test that's as good as exclusion. And humans, as we get older, actually tolerate dairy less and less. So that's one of the things that enzyme lactase, we produce it less and less. So if somebody tells you they're intolerant to dairy, they're probably right. So the question is it doesn't mean it's not like an allergy that's if you have to cut it out completely. It's a tolerance level. So you build up. You have to understand your own tolerance level. So if we're trying to work out lactose intolerance, we cut it out for 2 weeks, and if they're better, then you can say that you've solved their problem. And if they're improved, then you can slowly introduce dairy back. We talk about the fermentable dairy, so it's the fresh milk and the butter and the creams that are often the problem. The cheeses and the yogurt is often better tolerated. So, but if you're going to try work out lactose intolerance, you can do a breath test, it might give you an idea, but you have to go off and then introduce to it slowly and say, is it exacerbating my symptoms? That's a different thing to a cow's milk allergy, where the protein triggers an immune response. And we now, I've mentioned a controversial topic there about gluten, and every single second person thinks they lack gluten intolerant. You're not. Most patients with celiac don't know they've got celiac. They present with osteoporosis or iron deficiency anemia. They don't actually come in with major gut issues. Most of the people that are sensitive to gluten have irritable bowel syndrome, which is a functional gut issue. So if a patient comes into me and says they're sensitive to gluten and they think they've diagnosed themselves as celiac, I'd say that 99% of those patients are functional gut issues. The celiacs that I see come in with iron deficiency or with loss of weight or chronic diarrhea. And so gluten is it's another topic on its own. But if they are sensitive to gluten, they are sensitive to gluten, and you've got to believe the patient. But that they might be sensitive because they've got an irritable bowel syndrome, and cutting out gluten may help relieve their symptoms. If you've got a celiac, putting them on gluten is dangerous in terms of it increases inflammation in the gut, it increases risk of something called an intraoperative T-cell lymphoma. So they've got to stay away from gluten. Whereas if you're an IBS patient, you can maybe have a little bit of rye bread, and you don't have to cut out your salad dressing that's got probably a little bit of thickener and a bit of gluten in it. So I've answered that in a complicated way.
Yeah, answer my question.
Okay, we'll take one last question and then we're going to have to move on so we don't go over time.
First, thank you, Doctor. I just have a question. You mentioned, like, you know, having a wide variety of diets is good, but you also mentioned the Mediterranean diet, particularly for running. So, for example, like, if I'm training for comrades, how long before the comrades should I start doing the Mediterranean diet? And I would imagine you have to, like, do it gradually as well. I can't just go suddenly full on to.
So look, so the Mediterranean diet is just a healthy, generalized diet. That is a good diet that everybody should be following. It's making sure you've got enough fruit and veg and grains in your diet and limiting your red meat. So in terms of training for comrades, you've got to be cautious, and I'll defer to the sports medicine guys in terms of what they recommend for diet. But generally, you don't want to do anything dramatic, but I would start tomorrow if you could, or tonight. That's just for general health and well-being and preventing Alzheimer's and preventing cancer, because those have all been proven, and probably a bit of weight control. It's just generally, that's just good health. So I wouldn't do it as specifically for comrades. But if you're training for comrades, you've got to make sure that you eat having enough calories in your diet to maintain your muscle strength and weight. And I wouldn't suddenly change your diet 2 weeks before or even 2 months before. I would carry on what you're doing, and maybe just try to diversify slightly your diet, which basically generally means eating more plants.
Thank you very much.
But I'm not saying become a vegetarian or vegan.
Thank you very much. So our next speaker is Prof. John Patricius. He graduated from Wits Medical School in 1992. During his time at Wits, he ran the medics rugby team, was the president of the MSC, and served on the Wits SRC. At graduation, he received the Gilbert Cotterill Medal for all-round contribution to the faculty. Prof. Patricius underwent his postgraduate training in the UK and holds fellowships in sport and exercise medicine from the USA, UK, and Ireland. He is director of Waterfall Sports Orthopedic Surgery in Johannesburg and professor in the Faculty of Health Sciences at Wits University, where he leads the Wits Sport and Health Research Group. Prof. Patricius is the founder and director of Sports Concussion South Africa. He has promoted the need for more structured concussion evaluations in the youth and professional sport and has served as an advisor to SA Rugby. He is a medical advisor to World Rugby, UEFA, and the NFL. He is also an editor of the British Journal of Sports Medicine and is lead author of the recently published International Consensus Statement on Concussion in Sport. Please welcome Prof.
Brilliant. Thanks everybody for having me here. I'll speak quickly because I know that Jess Lansdowne has to get to a fitness test and I don't want to deny her that. But again, thank you for inviting me. Really, these are some of my favorite engagements, to see the new generation coming through. And I can hear from the questions that there's an enthusiasm which is great to feed off, actually. So thank you very much again for this invitation. I think it was unfair to put Dr. Jooste ahead of me. He's younger, better looking, and cleverer. And I happen to know a lot fitter as well. But anyway, I'm going to try and take a slightly different angle, but what I want to try and leave you with is an understanding that I enjoy my work. And I've often said to my parents, and we know our parents invest a lot in our education, that I've never regretted for one day of my life being a doctor. Never. It is a great, great privilege for you to be in this environment and to be becoming a doctor. It's really, I think, the most wonderful profession. And the fact that you can come at it from all these different angles that you're going to hear about over the months and years that you're part of this society, I think is a fantastic, fantastic thing. So Dr. Joost has already spoken a little bit about this, that really this is a discipline that addresses issues related to exercise. So the common denominator of all the people we see is exercise. And we'll discuss that in a little bit more detail. He's mentioned it's the newest specialty. Internationally, it's only about 2 decades old, sport and exercise medicine, and that is the correct term for it. It's not sports medicine, it's sport and exercise medicine. And the exercise is a critical part of it, because we often use this phrase, using exercise as medicine. It's very important. It's not just about treating Bafana and Springbok rugby players. We've mentioned the cross-disciplinary aspect, sport and exercise, and utilizing exercise as medicine. And the reason for that is that inherent in us is this need to move. So if you looked at what this environment in the cradle of humankind, which is where we are, was like nearly 3 million years ago, it really involved needing to move. If you couldn't move, you couldn't gather food, or you were killed. It's as simple as that. So inherent in our genetics and physiology is this need to move. And unfortunately, the way we've evolved, we've lost that to a degree. But from a sporting perspective, every single human sporting ability is the direct effect of selective survival pressures that were faced by our hominid ancestors. It was really a need to move that allowed you to survive. And in fact, it's no different today, because if you don't utilize physical activity, your chances of survival, and I'll show you evidence later, is far, far lower than those people who regularly exercise, and we can discuss how much is needed. So you need to exercise to survive, just as you did 3 million years ago. So being a sports doctor is very diverse, and you can come of it from different angles. So Dr. Joost here has been involved with high-level sport, but sports and exercise medicine physicians have varied roles across varied age groups, but the common denominator is exercise. We deal with people who are exercising, want to exercise, or should be exercising. It's as simple as that. Those are the 3 areas that we deal with. And it's a very diverse range of people. And if you follow me on social media, I'm not a big social media poster, but I try and bring that enthusiasm across and the need to exercise critically, very, very important. So if we define a few critical things, because quite often they're confused or merged, physical activity really involves any bodily movement produced by the skeletal muscles that requires energy expenditure. So getting out of your chair, getting out of bed, walking up the stairs instead of taking the escalator. Okay, it's not a planned activity, it's just that it's stuff that you do during the day rather than sitting behind a computer all day. So if you're physically active, it's because you move your muscles and you do stuff. Exercise is a subset of physical activity that is deliberate. It's planned and structured. So you actually set out to use physical activity to achieve a goal. And that would be called an exercise session. It usually has a repetitive aspect and has a defined goal. You're running 5Ks, or you're going to lift X number of weights, or you're going to walk this distance. I think you understand that. And then finally, physical fitness is a subset or a set of attributes that is health or skill related and evolves from physical activity and exercise. So if you're more physically active and you deliberately exercise more, you achieve a higher level of physical fitness. And those are all important because we know that measuring each of those deliberately can determine health outcomes. That's why you wear a smart watch and you monitor how many steps, what your heart rate is, and you submit it to Vitality, etc. And they monitor, because they know the outcomes are better if you are more physically active, you exercise regularly, and you have a higher level of fitness. So what does exercise mean to you? And we know to various people it can mean different sorts of things. And to me, it has a number of aspects. It has physical benefits. It has significant mental health benefits, which we know is a high priority in this day and age. And it has social benefits too. And we know that if you participate in sport, I'm not going to dwell a lot on this, but I've listed some of the physical benefits here. And it goes as far as promoting regular good gut function as well. We spoke about over-exercise, but the right amount of exercise is important. Cognitive. We know that kids that exercise do better at school, that you're actually likely to get through your day of work better. Ignoring your exercise as a result of having pressured medical studies is not a good idea. It improves your sleep, and especially team sports are really good at promoting social aspects. And in kids, learning to deal with success and disappointment, self-esteem and confidence, because despite what your parents might have told you, not everyone's a winner, I'm afraid. So our patients, as I've said, are exercising, want to exercise or should be exercising. And I always say my practice is 8 to 88. It's probably the most diverse field of medicine you'll come across. I don't know any other field of medicine that deals with that spectrum of age groups, the spectrum of abilities, the spectrum of disciplines that we have to, across genders, and then abled and less abled people. And so that's the network that we deal with. We heard about multidisciplinary. You have to, as a sports physician, have multiple skills, and you have to have a network that covers multiple disciplines. So it's fascinating because, I will be dealing with a child and be on the phone to a pediatric rheumatologist, and then the next I will have an elderly person there, and I'm speaking to an orthopedic surgeon, or I have someone with a gut problem and I have to speak to the gastroenterologist. So it's a fascinating area. And what makes it even more fascinating is that your disciplines extend beyond the medical field. So if you look at the bottom there, because you're often dealing with athletes, you have to deal with the sports team, coaches, administrators, boards of directors, sponsors. It's phenomenal. And that brings huge ethical dilemmas into it, because in any other realm of medicine, what goes on in that consulting room is private. In the realm of professional sport, everybody thinks they have a right to know about that patient's ankle or their gut problem or their psychological issues as a result of their divorce. Everybody can read about it, and with social media it's become even worse. And as a doctor, your opinions are often dealt with in a very public space. So just think of the ethical dilemmas of practicing as a sports and exercise physician in professional sport. Very different realm. And then obviously with kids, the prominence of sport in schools these days brings the family into it, and some of the issues deal with cognitive issues, and so the school and academic environment as well. So a very diverse range of skills. I think they teach that this well now at medical school is the biopsychosocial approach. Critical to dealing with athletes or active individuals. So when I was in medical school, honestly, we really focused on the whole biological, physical aspect. And we had significant shortcomings in addressing psychological needs and social context. Really, really important. If you've got someone in front of you, they have other stuff happening in their life which is going to affect the way they respond. And Dr. Barrow spoke about functional gut issues. This issue about functional diagnoses in medicine is coming to the fore. In other words, what's going on in your life, the rest of your life, will affect how you present to the doctor. And it's going to be different. If you don't take that into consideration and all those potentially influential aspects, then you're going to fall short as a clinician. I'm going to discuss 3 aspects of sport and exercise medicine. There's more to it, but just to leave you with a nice simple concept. The first are musculoskeletal injuries. In my world, that's about 70% of what I do. I deal with issues related to injury. And if I look at those, it's a bit of a busy slide this, but we divide them into 2 major groups: macrotrauma or acute injuries, and microtrauma or repetitive use injuries. And that's across the body. So it might be bones, it might be ligaments, it might be muscles, it might be tendons. Okay, so musculoskeletal medicine is a critical part of what we do. So you have to have good orthopedic skills, good radiological skills, and a good understanding of the integration of soft tissues with the skeletal system. I'm not going to go through it, but because of that we have a very systematic approach. that looks at history, physical examination, assessment, treatment goals, plans, and procedures, and I'll refine that a bit now. But, and I'm sure my colleagues are the same, I always think back now and think, I wish I'd paid more attention in fourth year. I mean, when they're teaching you those basic skills, I promise you, you're going to take them into your work as you go forward forever. So those basic clinical skills are absolutely critical. It's not a waste of your time. And the more you practice them, the more you ask questions and develop those skills, the more it will stand you in good stead going forward. So don't ignore those. So this is my formula to being a good doctor, because I'm simple. I try and break it down. And there's only 3 things I need to do. The first is to make a diagnosis. Okay, now that might sound simple, but I promise you there are a lot of clinicians that treat without a diagnosis. You must have a diagnosis, otherwise you're heading into the wilderness. So a lot of what we do is to get the diagnosis right. The second is to treat the condition. That's why the patients come. They want relief. They want to get better. And the third critical issue is you must address the causes. Take the dairy out of the diet, gluten, whatever it is. Stop them overtraining. Look at their biomechanics. And we divide causes into 2 groups. Intrinsic, something within your body. Okay, you're overweight. Okay, you're lactose intolerant. You've got leg length discrepancy. All those sorts of things. Or extrinsic, which comes from outside, which is principally 2 things. You've got the wrong shoes, okay, or you've got, you're overtrained. You're training incorrectly. Okay, so, you know, critical things. Jack's name has been part of the sports medicine world for how many years that you've had associations? 40 years, because people know how critical wearing the right shoes is. Okay, critical. If you're going to be a runner and you're in the wrong pair of shoes, finished. So that's how we look at things in terms of addressing the causes. Quite critical. Okay, the second part, musculoskeletal medicine is the first. The second is exercise medicine. Things associated with exercise that aren't necessarily musculoskeletal. And again, I don't think there's another specialty that covers as diverse an area. So if you look at my list of patients for the day, you'll see lots of musculoskeletal stuff, but you'll see things related to cardiac issues, fatigue, ENT, allergies, neurology, pediatrics, pulmonology, a lot of radiology, okay, and rheumatology because of the overlap. So it's very, very diverse. We use a lot of ultrasound in our workup as well. And the third area I want to talk to you about, which is often ignored, is that of parasport. Okay, it is a huge, huge area dealing with the less abled athlete. And this is so complex because you can imagine the range of impairments that you're dealing with. I mean, those of you that have watched the Paralympics, which has now received excellent prominence, will see the diverse range of athletes that you see. Some are sight impaired, some are cognitively impaired. You know, some have a range of physical disabilities. I mean, and quite often, you know, we ignore the types of injuries that happen in these athletes. And you look how hard these athletes fall, and you can see there might be musculoskeletal injuries. There are going to be a lot of concussions involved in cases like this. So it's a fascinating area. And if you have an interest in that, you can make a whole career out of dealing with parasport athletes. Cardiology is an important part of things. The heart is really central to what the athlete's trying to do. But it's not simple. In fact, it's more complicated in exercise medicine because we have this concept of the athlete's heart. Now, what you're doing when you're exercising is you're actually developing cardiovascular capacity. And part of that is you change the anatomy of the heart. So the heart becomes bigger and thicker and more efficient as a pump, quite simply. And that reflects on how that athlete presents. So if you look, I don't know how many ECGs you've looked at yet, but if you look at that, you'll say, whoa, this doesn't look great. Okay, look at some of those repolarization changes on that. But in fact, this is actually a normal variant, particularly prominent in black athletes. And so what I'm trying to show you is the spectrum of normality in healthy, fit athletes is different. And so it's not just the abnormal we deal with, but different spectrum of normal. Very, very interesting area. And if you want to watch some really good YouTube talks, go and look at some sports cardiology talks. Another example here of a normal variant in a young athlete. So just something, food for thought to take home, that the actual normal in athletes is different. So you've had two excellent case examples. I've opted to do something different without your permission, is to just look at a range of cases, because I want to show you the variety involved in what we do. So you will see, here we go. This is a neck injury in a young varsity cup player. Look at that prolapsed disc. Okay, this patient presented with bilateral arm and interscapular pain. Then you'll get this, I'm not sure if you can see that easily there, I don't know, but there is a pointer that's sort of pointing to it. So this was a stress fracture in a distal fibula in an athlete. So those that present in the tibia, which is the major weight-bearing bone, are often very symptomatic and present early. The fibula often presents very, very subtly. So you can see a subtle fracture line through there. You can have a look over there. And then you can see new callus formation laterally there as well. So nice, subtle, and amazing what a normal X-ray can give you if you know what you're looking for. Okay, here's the other spectrum. This is my 8-year-old patient who just wants to keep walking, playing a game of paddle twice a week. Osteoarthritis. The principles are the same. We have to keep them going. How are we going to do this? Conservatively, interventionally, with surgery, etc. But that's the sort of spectrum of patients that we deal with. Okay, this is an interesting one because it's the other end of the spectrum. And if you give this X-ray to many radiologists, they'll report it as normal. But what you're actually seeing here is what we call an ischial apophysitis. So where the hamstring attaches on the ischial tuberosity, you can see that black line there. The growing portion of the bone is irritated by the hamstrings in this athlete which are pulling. And it's damn sore and it hurts them. And sometimes they avulse. Again, so you've got to look at the spectrum of normality. So what do? Rest a teenager for 6 months? Or do you find a way of managing it that manages the loads and the mechanics, the intrinsic and extrinsic causes, to allow them to keep going? So again, very interesting area of medicine. So this is to show you that no one escapes unscathed. This is actually my X-ray. Okay, a big heel spur, which actually I failed to treat effectively, conservatively, and I actually needed operated on. And that's the osteophyte being excised. So again, even though I'm not a super athlete, it was stopping me from exercising, and eventually I needed surgically addressed. Okay, here's a nice rotator cuff calcification that we used to 10 years ago have to treat surgically. Now we have good interventions that we can utilize, including ultrasound guided needling techniques and extracorporeal shockwave therapy that we can do in our rooms. Okay, so huge advances in terms of how sport and exercise medicine can address those. Anyone guess what that is? It is got a bunion, but on top of that, if in doubt, think of gout. Okay, so you'll often go somewhere, I've got an injury to my foot. Not, it's gout. Okay, nice big gouty tophus there. Okay, this was a life-defining case for me from last year. Okay, this was a young 16-year-old, young netball player who came in. She had been playing with pain for 3 months and came at the end of her season. The knee's getting worse, worrying her at night. Okay, her X-ray showed on the right there what we call a sun ray appearance, and actually she had an osteosarcoma. Okay, so just to show you that not every case in sports medicine is a sports medicine case. She underwent 3 months of chemotherapy at Donald Gordon, had limb salvage surgery, and then another 9 months of chemotherapy, which she finished 2 weeks ago, actually. And unbelievably, I actually had 2 cases like this in 2 months. The other one was a 12-year-old hockey player. So just to show you that you can never lose your guard, that just because someone's presenting to a sports medicine clinic doesn't mean it's a sports medicine case. Vast variety. You will have heard one of my areas of interest is sport-related concussion, and that's because of incidents like this. So we never knew really 20 years ago what was happening in that athlete's brain, why it switched off like that. And that's because we didn't have any visible wound. So all our regular tests and investigations into that athlete would be normal, including regular brain scans, CAT scans, MRI scans. And what's evolved over the last 20 years is a very structured set of functional assessments and interventions that allow us to determine what's happening in that athlete's brain. And we now have huge data sets of normative data and what we call baseline data in athletes that we can compare them to. Not structural information, functional information. How did their brain function and their body function before? How does it function after? It's a fascinating area of interest. And we use technology as well. So this is one of our Springbok rugby players using a virtual reality technology that we use that looks at what we call vestibular ocular assessments. It looks at the integration of the eyes, the balance system, and the brain, and the proprioceptive systems, and looks at how well that is working. But you can only do that by stressing them and testing them. And then we utilize similar interventions to rehabilitate them. We never used to do it. We used to put them in a dark room 25 years ago. Now we do the opposite. We expose them to normality and cognitive and physical stress soon. Okay, it's a fascinating area. But again, there's the spectrum. We spoke about stress fractures, cancers, and neurology in 1 minute. Okay. We'll talk about a little bit of an exciting era at Wits, and that's the evolution and the growth of sport and exercise medicine. So about 8 or 9 years ago, the then dean approached me and he said to me he would like me to become involved to try and boost sport and exercise medicine here, which has been really an exciting part of my career. And we started off as what we call WISH, or the Wits Sport and Health Research Group, which we are. And we're growing this into an established discipline at Wits, where we actually are involved in publishing some really nice stuff. We've published some good research on viral infections, vaccination, and recently on the effect of physical activity on cancer outcomes. So we've really boosted sport and exercise medicine research, and we've created much stronger networks around Wits. And the aim is to try and grow sport and exercise medicine in 3 realms. One is in clinical service delivery, so to have sports medicine services on campus, and I'll show you where that will be now. The second is in academic, so to grow exercise medicine, and I hope you've noticed that some of it is starting to come into the curriculum. You will have some lectures talking to you. Professor Torres is really doing a good job about bringing in exercise medicine into undergraduate curriculum, and then offering a registrar program in sport and exercise medicine, which is our ultimate goal, and then research, as I've mentioned. So when Jess goes across to her hockey practice there, she's going to see a big building site across where the pool is, and that's going to be the new Wits Institute of Sport and Exercise Medicine, called the Zalstra Center, a very, very generous donation by alumni of this university, allowing us to build a 250 million rand facility on the education campus. So the foundations have been dug there, and we hope to have that finished by June 2026. That will allow for the housing of a multidisciplinary environment for sport and exercise medicine. Sports medicine clinic for sports physician training, some specialized orthopedic arthroscopic training areas, physiotherapy, biokinetics, podiatry, and a hydrotherapy area in the swimming pool. So a very nice, exciting area. Needs a lot of work still from an operational point of view, but we're very, very excited about it. There's some sketches of what the building looks like, and as I say, we've started to break ground, and we should see that coming to fruition soon. So there will also be new lecture facilities there. So I'm going to end off, because I started off telling you how I enjoy my work, so hopefully the volume is good enough for you to hear this. Let's start it there. Okay. So this is to try and entice you into sport and exercise medicine. Here we go. Can you hear this coming through?
Drop it a little bit louder.
Let's try it. There we go. That's why you shouldn't do the other specialties.
There's aspirin, adrenaline, and also aminophylline, amphetamine, adenosine, augmentin, and rifampicin, amoxicillin, penicillin, heparin, and warfarin, and estrogen, progestogen, and canesten, and chloroquine. There's bendraflumethiazide, and also cyclophosphamide, and metoclopramide, acetazolamide, tropicamide, loperamide, amiloride, and cyclazine, and fusamide. And if you're up the duff, then you'd best avoid thalidomide. There's lithium, fluoxetine, and also amitriptyline, paroxetine, digoxin, GTN, and azathioprine, meconazole, atenolol, and also chloramphenicol. And if you want to overdose, there's always paracetamol. There's nitros, and phenytoin, Zyrtec, and diazepam, and lithium, temazepam, midazolam, clonazepam, testosterone, aldosterone, and Valium, and insulin, and lignocaine, and piriton, and Ventolin, and Ritalin. There's cefuroxime, cefotaxime, cefolex, and cephodrin, and metronidazole, and ketoconazole, trimethoprim, erythromycin, gentamicin, macrolides, mifedapine, and Actifed, and Sudafed, and Calpol with no sugar in. There's phenelzine, and hyoscine, ranitidine, cimetidine, potassium, and calcium, and every kind of vitamin, and pethidine, and methadone, and speakercane, and heroin, and cannabis, and Prozac, morphine, alcohol, and nicotine. You must remember all these drugs, the names of which you've learnt from me. Or fuck them all and get a job in orthopedic surgery.
Okay, thanks very much. And while I do my orthopedic surgery, I just want to tell you about Dr. Barrow here. He's actually from a famous Johannesburg orthopedic family. So his father was one of the most well-respected orthopedic surgeons from when I was studying here. And three brothers, eh? The Barrow brothers, I think, are sort of also interspersed between them. All became orthopedic surgeons, and here you've got the runt of the litter who
She's a surgeon.
So yeah, I mean, a great honour to speak with Dr. Barrow, because I studied with the Barrows. I won't tell you how long ago. Any questions?
We are going to limit questions just a little bit because we are running over time, so we're going to take 2 questions. So raise your hands and ask quickly, please.
Yes.
Doctor, so I'm just curious with the concussion. Do you know of any data where for kids in the same age group, so school kids, is there difference in incidence in concussions between kids born, beginning of the year, like 1st of January versus the end of the year?
So I don't know of those data, no. Concussion's complex, so there's many, talk about addressing causes, there are many potential causes for that, but there's no, so what you're saying is exposed to the same age division, but some born in January, some in December, like we have data on sports performance, that the kids that are born later might perform better. No, I don't know of anything, to be honest, and I don't want to try and speculate because I don't know of any. Yeah. Yes, the back.
So I just also had a question regarding the concussions and head injuries in general. So I understand that like CTE becomes a concern when you have long-term exposure to head trauma. I was wondering if there's a lot of research supporting preventative measures for CTE, because as far as I've seen, headgear and stuff like that has actually proven to not have much benefit.
Okay, just to contextualize that, so CTE stands for chronic traumatic encephalopathy. It's a post-mortem pathological diagnosis. So pathologists see it on a slide when someone has died, and it's a very sort of structured pattern of changes that occur around the sulci in the brain, particularly around the vascular changes. And it's speculated that one of the causes may be repetitive head trauma, and that one of those causes may be in collision sport athletes. So it's a very contested area, and it's not black and white to say if you've had so many concussions you're going to end up with a diagnosis of CTE. And it's complicated by the fact we can't diagnose CTE in live individuals. Some of them, it's speculated, may have presented with premature dementia. And we do have some research that shows in some cohorts of American footballers and soccer players that there is an increased incidence of neurodegenerative disease. There's about to be a study published, longitudinal study, looking at New Zealand rugby players from 1950 to 2010, and it shows a very slight increase in neurodegenerative disease propensity. But having said that, in every other measure of health, the rugby players perform better. Lower cancer incidence, lower cardiovascular incidence. So overall, they were much healthier. And the high incidence of neurodegenerative disease came much later, many of them over 70 years of age. So it's not clear-cut. And the Lancet has identified, the Lancet Commission identified 14 causes of dementia. And repetitive microtrauma or head trauma is one of those that accounts for about 3%. The other 97% are other things like poor education, smoking, high cholesterol, high blood pressure, lack of physical activity, all those sorts of things. So it's not simple enough to say you've had a concussion or 3 or 4 or 5 or 10 concussions, you'll end up with neurodegenerative disease. It's a very complex topic. It's highly emotive in the sports concussion environment because there are a lot of people that make money out of it. And as you know, it's legally prominent at the moment because there are cohorts of professional sportsmen that are suing based on some of the evidence that is out there. So it's a huge area. We could have a seminar on its own on that topic.